cell carcinoma, which is the second most common carcinoma of skin. What is the etiopathophysiciology of squamous cell carcinoma? The squamous cell carcinoma is the carcinoma which is arising from squamous layer of the skin. The risk factors are exposure to UV light. We know that exposure to UV light is the risk factor for all the three carcinomas: malignant melanoma, squamous cell carcinoma, and basal cell carcinoma. And all the precancerous conditions like Bowen's disease, which we discussed in morning, Paget's disease, actinic keratosis, radiodermatitis, and chronic scars, which we discussed extensively under pre-malignant conditions of skin, are risk factors for squamous cell carcinoma. Smoking and HPV 5, 16, and 18 infection has been associated with squamous cell carcinoma. Characteristically, we see P55, P53 mutations in 90% of patients. We all know that P53 is a tumor suppressor gene. When this tumor suppressor gene is mutated, it leads to uncontrolled proliferation, leading on to development of carcinoma. What are the clinical manifestations of squamous cell carcinoma? Clinically, we have different types of squamous cell carcinoma. That is ulcerative type, ulceroproliferative type, and red nodular type. The ulcerative and ulceroproliferative type presents with skin lesion which has raised and everted edge with indurated base. We know that induration is seen in case of squamous cell carcinoma and basal cell carcinoma. Induration is not seen in case of malignant melanoma. We also can see bloody discharge coming out of the lesion. Commonly, squamous cell carcinoma is associated with lymphatic spread. And if there is lymphatic spread, the lymph nodes will be hard and nodular. Initially, the lymph nodes will not be fixed. With time, they become fixed and immobile. We saw clinical manifestation, that is lesion and lymph node status. And what about spread of cancer? Usually, squamous cell carcinoma doesn't metastasize in hematogenous route only if the lesion is very large or there is deep infiltration of the lesion, and if the lesion is poorly differentiated. In 5% of patients, we see hematogenous spread to the lungs, liver, CNS, etc., leading on to secondary manifestations. This is all about clinical manifestation, about lesion, lymph nodes, and hematogenous spread, which is rare. Now, how to investigate squamous cell carcinoma? We have wedge biopsy of the lesion. Wedge biopsy. What is wedge biopsy? We take triangular section of the tissue, the diseased lesion, and then we do histopathological examination. On histopathological examination, we can see keratin pearls with malignant squamous cells with atypia. And also, characteristically, squamous cell carcinoma has cytokeratin 1 and 10 positivity on immunohistochemistry. If we do FNSC of lymph nodes, we can see secondary metastasis where we can see squamous cells with keratin pearls. For nodal spread, estimating nodal spread, we can also do CD scan in the patient. The MRI may be useful to evaluate the local extension of the lesion. The local extension of the lesion can be evaluated by doing MRI. Now, how do you treat the disease, which is squamous cell carcinoma? The lesion, we usually do wide excision of the lesion with 2 centimeter margin, followed by covering of the defect by skin grafting and flaps. Or also we can do MOHS procedure, that is microscopic oriented histographic surgery, where the surgeon will remove the cancerous tissue layer by layer. Following that, a histopathologist will examine the margins of the lesion, will examine the margins, If the margins are clear, it means that the tumor has been excised completely. If the margin has malignant cells, we will excise the margin. The clearance will be done in the diseased margin. Why this is done? That is MOHS, microscopic oriented histographic surgery, is done. Instead of doing wide excision, we can slowly remove the lesion to up to the diseased margin. We can accurately pinpoint the margin and then excise the tissue which is only diseased. This is about MOHS, microscopic oriented histographic surgery. If the patient has advanced disease and the lesion is extensive, we can perform amputation with one joint above. Now, squamous cell carcinoma is radiosensitive. If the patient is not fit for surgery and if there is a recurrent squamous cell carcinoma, we can give curative radiotherapy for the patient. And also, if the disease is very extensive, if the patient has extensive disease, we can give palliative external radiotherapy for the patients. After this local excision and radiotherapy, we can consider chemotherapy to the patient, where we can give methotrexate, vincristine, and cisplatin. To summarize, we saw etiopathophysiciology of squamous cell carcinoma. There is factors, and also I missed one risk factor, that is immunosuppression. That is intake of azathioprine and cyclosporine is one of the risk factor for squamous cell carcinoma. The exposure to UV lights, precancerous conditions, and p53 mutations are seen in case of squamous cell carcinoma. The clinical manifestations, we have ulcerative, ulceroproliferative, and red nodular lesions with raised or everted edge, indurated base, and bloody discharge. The lymph nodes, we have hard and nodular lymph nodes, which are initially not fixed. Later, it becomes immobile and fixed. The hematogenous spread is rare. Only in 5% of patients we see hematogenous spread. The investigation, we can do wedge biopsy of the edge, FNAC, CT, and MRI. The treatment, we give lymph node excision. So I missed lymph node excision. If the lymph node is involved, we'll do lymph node dissection and removal of the lymph node, diseased lymph nodes. The treatment of lesion, we can do wide excision, MOHS procedure, microscopic oriented histographic surgery, amputation of the limb if the disease is extensive, radiotherapy, which can be curative or palliative external radiotherapy, and then followed by chemotherapy, methotrexate, vincristine, and cisplatin. This is all about squamous cell carcinoma. Another 5-mark question. Basal cell carcinoma, we all know it's a low-grade, locally invasive carcinoma, where the tumor in case of basal cell carcinoma will not metastasize through lymphatics and through blood. Rather, it goes deep into bones and cartilage. So it's called as rodent ulcer. Why? Because similar to rodent, which make burrows in our house, it makes burrows deeply, it invades into bones and cartilages. What is the typical location of basal cell carcinoma? Around 90% of basal cell carcinoma is seen above the line joining ear lobule to angle of mouth. Above this, 90% of lesions are seen. Here you can see the lesion of basal cell carcinoma. What is the etiopathophysiciology? As with malignant melanoma and squamous cell carcinoma, we have UV rays exposure as a risk factor. We have other skin conditions like albinism and xeroderma pigmentosa, leading on to basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. These two conditions are risk factors for all the 3 malignant conditions of skin. We have chronic exposure to coal tar, the hydrocarbons, aromatic hydrocarbons, and radiodermatitis, etc., etc. The chronic insult to the skin as a risk factor for basal cell carcinoma. What are the types of basal cell carcinoma? Based on appearance of the lesion, we have nodular type, where we see nodular lesion, skin lesion. Nodular skin lesion meaning it has length, breadth, and depth. It is the most common type of basal cell carcinoma. Followed by that, we see nodulocystic lesions, ulcerative lesions, and also we can see pigmented lesions. This pigmented basal cell carcinoma confuses us, makes us confused with malignant melanoma. Based on behavior of the tumor, we have geographical or forest fire basal cell carcinoma, where in this type of basal cell carcinoma, the spread of the tumor spreads rapidly into the surrounding tissue with a central scab. The edge of the lesion is proliferative. The center of the lesion is not proliferative, but the edge is proliferative, leading on to spread into the surrounding tissue, rapid spread into the surrounding tissue, similar to the forest fire. So it's called as geographical or forest fire basal cell carcinoma. We also have other type called basosquamous carcinoma. The basal cell carcinoma, we know, it doesn't spread through lymphatics and hematogenous route. It only locally spreads. If there is spread of basal cell carcinoma through lymphatics, similar to squamous cell carcinoma, which is called basosquamous type of basal cell carcinoma. Now, what are the clinical manifestation of the lesion that we see in basal cell carcinoma? The lesion will be non-tender, meaning the patient doesn't have pain on palpating the lesion. The lesion is dry and slow growing. Also, the edges of the lesion is beaded. The beaded edges of the lesion is the one which is having active proliferation. That is cancerous cell showing active proliferation. Whereas the adjacent normal skin doesn't show active proliferation. And also characteristically, we see central umbilication or dipping in case of lesions of basal cell carcinoma. Now, how to manage this condition? How to manage basal cell carcinoma? Similar to squamous cell carcinoma, we take wedge biopsy and do histopathological examination, where we see squamous, the dysplastic cells arising from basal layer of skin. And upon doing X-ray, if the bone and cartilage is involved, we can detect it by doing X-ray. The local spread and involvement of bone can also be detected by using CT scan. Now, what is the treatment of basal cell carcinoma? The treatment of basal cell carcinoma is curative radiotherapy. Curative radiotherapy because the basal cell carcinoma is very sensitive, radiosensitive. So we can do curative radiotherapy only if the basal cell carcinoma is away from eyes, or else if the basal cell carcinoma is near to the eye, we can't do radiotherapy because it damages the cornea, it damages the eyelids and leads to secondary complications. So curative radiotherapy is done when the lesion is away from eyes and the lesion is not involved bone and cartilage. In those cases, we can do radiotherapy. In other cases, we perform surgeries like wide excision with 4 to 6 mm of margin. After wide excision, we do skin grafting and placement of flap. Similar to squamous cell carcinoma, we can do microscopic oriented histographic surgery in case of basal cell carcinoma. This is all about basal cell carcinoma. We saw basal cell carcinoma is a low-grade, locally invasive tumor invading bone and cartilage, which is seen 90% of is seen between the angle of mouth to ear lobule, above the line joining angle of mouth to ear lobule. The risk factors we see, it's more common in white skin people, exposure to UV light, chronic exposure, skin irritation due to coal tar, aromatic hydrocarbons, The skin condition like xeroderma pigmentosa and albinism are the risk factors. The types we saw: nodular type, nodulocystic type, ulcerative type, pigmentatory type, geographic type, and basosquamous type. Then clinical manifestations: the lesion is non-tender, dry, slow growing, with beaded edge, which is a site of active proliferation, with central dipping or umbilication in the lesion. How to manage? We saw investigations and treatment. In treatment, we do curative radiotherapy, followed by surgery, that is Weiss excision, and MOHS, that is microscopic oriented histographic surgery. This is all about basal cell carcinoma.